Hi, I'm Elham Ketchum, and I am a recruiter here at Tidewell, and we thank you for your interest in becoming a part of our team. We put this video together because we hope that it will really show you what it means to work here at Tidewell. I know that by now you have read a job description, you have maybe talked to some folks, and probably even you and I have had a conversation over the phone. But the best way for you to really understand what a nurse does here at Tidewell is to hear it from them in action. So we also hope that this video will generate some questions. You know, some great things about working here at Tidewell. Our nurses will tell you that they get to spend time with their patients, and I even attended an interdisciplinary group team meeting just recently, and not only did they spend time with their patients, but they knew everything about them. And one patient that really particularly stood out in my mind was a gentleman, and they didn't just know the gentleman's condition, but they knew all three sons, all by name. They knew how each son felt about their father's current condition, and I just thought they have really become a part of their family. And while all of that sounds wonderful, there are rewards in this position and there are challenges in this position, and we want you to know both. We want to make sure that you have a really realistic understanding of this job. So we thank you for your time and enjoy the video.
When I first tried it, I was so green, I so knew nothing about hospice. It was really, I took a chance. I needed a job and I was offered a job, and I wasn't sure at the beginning. It was so different, so intense. I wasn't sure that I was gonna be able to love it. I saw things when I came to hospice that I had never seen in my life. It stands to reason people are at the end of their life. So you're gonna see the most severe of wounds, the most severe cachexia, and smells are intense.
You know, you don't lose any of the skills that you do, say, working on a med-surgical floor, because a lot of these patients come in and they may have chest tubes or, you know, pleuric tubes or trachs.
I wish I knew when I started how much I was gonna have to know, because it's tough.
I worked at another organization that had the same pillars that we have in Tidewell, and I always felt, to me, it was like a little bit of like lip service to the pillars, where I've not felt that with Tidewell. It seems like everything that I've just found so much integrity within the organization. Even with the orientation was just absolutely incredible to me.
My first day of orientation, I precepted at another hospice house in Port Charlotte. Everybody there was open, friendly. The clinical director, do you have any questions? What can we help you with? What are you comfortable doing? The preceptor, she was just excellent with her patients in transitioning me from that acute care level of thinking to the end-of-life level of thinking.
Some of the dressings that we have, some of the wounds we have, were very involved, and I hadn't even thought about that ahead of time. And I don't know why I didn't think of the dressings and the wounds, because you figure the whole body's shutting down, you're gonna have wounds, and I don't know why I didn't see that coming.
You have to take care of yourself through that learning curve, because you're learning so much. And you're also having a lot of emotional strife, I guess you could say.
Everything is in its severest form. So was I shocked? Yes. That became the challenge to me, that they want to feel as loved and human and beautiful as someone who doesn't have that ailment. So you have to figure out creative ways to make them understand that they still are valuable and beautiful.
Labor and delivery is its own specific field of nursing, or cardiac is its own specific way of nursing. Hospice has its own way of nursing. You can't come in and think, just because you've worked in a hospital, that you're going to know everything about the dying process.
There's a lot of things that are totally particular to hospice. How you use the drugs is completely different than how they're used in the hospital. The dosages are different, the titrations are different, when you use them is different.
Hospice houses That's kind of like doing floor nursing. The home teams, you're on the road all the time. You have an assigned set of patients. These patients live at home. They may or may not have a caregiver with them. And you really are their like sole point of contact for what's going to happen to them within the hospice domain. The long-term care settings, our patients there reside in a long-term care facility. It's usually a skilled facility, so they have their own nurses, they have their own doctors. And we're going in there as a hospice nurse and advising and helping provide the end-of-life care. And then the ALF team, that's kind of in between both the home team and the long-term care. So those parts are all very different. And that's another thing I wish I had known coming in too, because you get used to working the home team where we're using all our hospice doctors. Then you go to the long-term care team the next day and you can't use our doctors, you got to deal with their doctors. And then you have the ALF, which is sometimes this weird mix in between.
When you are trying to get a patient comfortable, there's not an algorithm that you can follow to accomplish that goal. You have to intimately get acquainted with that patient's body, with their mind, their spirit. It's never the same. No two patients are ever the same when you're managing their symptoms. So that's why I liken it to a wonderful creative art.
Really the thing I found with Tidewell is the main difference is we do it coming from a place, and it kind of sounds sappy, but really we do it coming from a place of emotion and compassion. And that's what I really like about it, because it's not just take these steps because this is the ultimate goal. It's we're taking the steps, but with each step we're thinking about it, how it's going to affect the patient, how it's going to affect the family, and we're doing it in an emotional way. You know, we're doing it with kindness and compassion.
Tidewell, I think, is the closest thing to textbook nursing. It's not just symptom management. Like, I can hold a patient's hand and, tell them that it's okay, and I have the time to do so.
It's much different from a hospital setting where all you're doing is, okay, how am I going to fix that, or how am I going to get this patient better, or I can fix that, surgery or IVs, antibiotics, this has to be fixed.
The psychosocial part was a huge part of the learning curve. Totally different when you're seeing these patients day in and day out, usually a couple of times a week. You become their lifeline.
Not only are you admitting and taking care of the patients and families, you're also helping them to understand that there are different options out there in contrast to what their acute care options are.
I would say, you typically had 5-6 visits a day that were an hour each, and so you had a good couple of 2-3 hours on the road every day.
It was 100% traveling, yep, and it was all over the place because I was originally hired as a PRN in the South District, so that's kind of like from Venice and south, Port Charlotte area, and I live here in Lakewood Ranch, so it was a lot of traveling. Yeah.
There is travel time. We occasionally have meetings, and coming from this location, we can travel 100 miles to and from to another hospice house, but we do have compensation for that. We are paid mileage, which is a definite plus that a lot of organizations don't do, so that was something surprising when I came to Tidewell.
So I've got resource books, which are an admission nurse's best friend. I've got blue packets, which I keep back there because I usually just grab one of those when I get out of the car. And then this just has some dressing supplies in it. I keep gloves in here.
On a typical day, I stop here at the physical office and pick up any paperwork or whatever I might need for the patient. And then I get into my mobile office. Home team nurses carry what we call a mobile supply closet. Has everything that we may or may not need for a patient visit. Wound care supplies, Foley, specimen cups, even gloves, hand washing equipment. A reliable vehicle is essential.
With any electronic medical record system, it's only as good as what you put in it. So if you want it to be that good, you have to spend the time to put in the proper information to it. And that's a challenge because we want to spend our time as nurses. We want to spend our time with the patient rather than charting on a computer.
This is my air card. So everything I put in the computer, this is my internet. So everything I put in the computer, and then I sync it, and it goes up into a magical place in the sky and goes to the main place up at Rand. Everything is in this computer. I can't do anything without it, so I guess it's pretty important.
You have to, get up to speed with your computer skills, and you have to not be afraid of them, and you have to learn to integrate them with your patient care. Because I can't tell you how many people want to just do the patient care and then take the computing part and do that afterwards. And that's just, you can't do that. Especially since we're working with a system that's, everything's supposed to be up to date quickly. If you're waiting to do your charting till later, then somebody else who's looking at information on this patient isn't getting the most up-to-date information. And that's what this system is really great for. And if you're bypassing that step, you're really doing a disservice to the patient actually.
Charting bedside makes things a lot easier. Our phones obviously are very important tools because everybody calls us. That's how they get a hold of us, is by our telephone.
And anytime regulation comes down the line, that means more complexity is thrown into your system. So your charting needs usually go up.
Once you get your appointment, you can find clinical information in regards to what's been done so far for the patient, so you've got an idea. So this patient lives in a Ukrainian complex, so I may be having a language barrier. We'll see. And I know that her diagnosis is Parkinson's, end-stage Parkinson's disease, and it looks like she signs things with a stamper, so we've got some information here that I know ahead of time going in.
At Tidewell, they're interested in maximizing patient time and minimizing computer time, but again, finding that balance will always be a challenge in the medical field.
For me, it's not one of those things of, oh, I'm going to leave because I can't stand that. Because nowadays you're going to get that wherever you go.
I'm not a big computer guru, and so it scared me when I first found out everything was by computer. But there's always somebody that knows what you're stuck on. So don't fear the computer.
Well, it's a different kind of nursing for sure, in terms of you need to be available to the families on an emotional level. You need to be there for them. When you walk into a room, you have to not only assess your patient, you have to assess the family.
In hospice nursing, and particularly in the home team, we're going into their home, we're being invited into their homes. You get to know everybody in the family pretty well over a period of time. And that aspect is different because then you have all the personalities that you have to either deal with, get along with, or work around.
Every family grieves different and every family unit is different. You have patients and families that are coping very well, that talk openly about death, they know that the end is near, and you have patients and families that aren't accepting it and aren't ready.
We continually, every single day, walk into crisis situations. New admissions have just gotten the word that their prognosis is 6 months or less. Biggest challenge, and that is that some people don't realize that we're there to help. They don't want us to take over everything, or they don't want us to take over anything because they don't want this diagnosis.
We've had family members withdraw do not resuscitate orders as the patient is expiring, and we have to send a patient out to the hospital or begin resuscitation. And it's just an ongoing education process and support process, and have to remember that no matter what, the patient and family has the choice.
Thinking about that, I've been thinking about the relationships I've had in this room just with families. You do get quite close to the families, more so than you would in a hospital setting, just because you're there in emotional capacity for the family.
So you're going to spend a lot more time than you would in the acute care setting where you're assessing, providing medications, and focusing on curing. You're really just spending a lot of time managing symptoms and education and support.
Families can be angry, they can be in denial, and in some cases when they're angry, they have a tendency to take that out, especially on the nurses or the nursing staff.
Patient's family got into a fist fight in front of me, and my primary thought was to get out of the house and run, but I wanted to make sure the patient was okay, and without myself getting involved in the situation, I just kind of sat with the patient and said, you guys need to take it outside. Usually people are in their best behavior when you're there, not always.
Some families feel guilty if they're not there when it's time, and they'll sit vigil at that bedside and not leave for anything. And I'll say, no, it's okay, you gotta take care of yourself, get up, go to dinner, as soon as they leave, the patient will pass. And so I always try and tell the families that wherever you are, when they pass, that's where you were supposed to be. Some of it sounds silly, but after you're here for a while, you'll start seeing things that give you goosebumps. The patients that can wait for a birthday, the patients that'll wait for an anniversary, they'll wait till last family member comes in, or they'll pass before they come. And I always think, well, they didn't want to put that family member through it.
And you're always going to have a particular patient that tugs at your heartstrings. And you sort of have to find that balance of providing the compassionate, patient, tender care that patients need, even for the patients that you're not drawn to. And then on the other side, you have to have boundaries on the patients that pull at your heartstrings.
Well, if we didn't care, we wouldn't be human. So you have to care about what you're doing, and you have to be able to sympathize and empathize with the family without overstepping the bounds, of course, because if we didn't care, we wouldn't be here.
You need to be caring and compassionate towards these patients, but at the same time realize they are going to die. So kind of emotionally distance yourself, or put up maybe a little bit of an emotional wall so that it doesn't tear away at you when you walk away at the end of the day.
You know, if it's somebody's father, it's not my father that's dying, it's their father. And sometimes when I get too involved, I try to remind myself that I'm not I call it a grief thief. It's not my grief, that really I've known this person my whole life. I've only known him for a few weeks or months, so I try to back myself off.
Yes, you can't help yourself with that. You do become attached. One patient, just something about that patient that you gravitate to, or they gravitate to you. You just have to remember, though, at the end of the day that, you know, this is still a job for you. You come in, you have the compassion, you do what you need to do, but you yourself have to take care of you. And you also have a family, or, you know, outside of this, so you have to be able to balance that all together.
I think it helps to, you know, talk with other people who do the job that we do and that are experiencing these you know, experiencing death a lot, because it's certainly not a normal thing. And then, you know, you get to share your stories about people constantly asking you, how do you do this job? How does and it makes us all feel good. So then you're like, we're not the oddballs, which is cool.
We have a nice screen lanai, and been out there with families before, and then suddenly they start sharing something, and then boom, next thing you know, you got tears welling down your face, which is nothing wrong with that. You know, you have to still have a job to perform. So not to say that we don't feel emotion, and not to say we don't feel emotion deeply, but you have to be able to kind of know when to kind of draw the line and say, okay, I can feel this. It's not going to affect my ability to care for you, or it's not going to affect my ability to make good decisions.
And that's hard. If you've got a 27-year-old, it is hard to let that go. You know, that would be my child's age, and there's little things that draw you to patients, whether it's situational connections, or, you know, it can be any number of things, and it becomes a discipline to not allow yourself to become overcome. And that's a real problem with hospice nurses in general, is we have to really have tight boundaries.
You have the time with them to talk more, to educate more, and to develop that interaction. And you know, you develop personal bonds with them. You know, you have to be careful about maintaining your professionalism, but you can't help it by, you know, getting attached to some. And it's just, I think, one of the good things about what we do.
You have to relinquish the reins, even though it can overcome you, and you can feel that burden that you're responsible 24/7. So you have to remind yourself, I'm not. On the weekends, in the evening times, whatever your off time is, it becomes a discipline to let that go and to realize somebody else is in charge tonight, somebody else is in charge this weekend.
One of the nurses used to say, it's not about you. And I've used that before too, when you you feel yourself getting upset by a situation or a person or a behavior, it's not about me. And that kind of removes you from the equation. You know, that's right, it isn't about me.
There's really a very collegial feeling. We support each other. And if one of us has had a particularly bad experience, and by bad I mean you've given a lot of yourself to that patient. And when they die, sometimes it does take a toll on you. You know, you do find yourself tearful. That's not with every patient by any stretch of the imagination, but there is that one that will get your heartstrings.
All right, when I think of difficult conditions, I think of either danger or unclean conditions. Usually the first point of contact will make note of that so that follow-up nurses will know going into the situation, and they'll advise you on things like that. Because there are always steps we can take to minimize our risk in going to an environment like that.
I've had several homes that have had bug infestations. I don't take any equipment in with me except for what I need for that patient. Not even a computer. I don't chart bedside. I go in, take care of the patient needs, do what I need to do, and get out. Because if I bring my bag in or my computer, bugs can get all over that. I take it to the next patient's house, and guess what? Now they have cockroaches.
I mean, I've been in houses where you walked in and there's a can of Raid on every countertop in the home. So you just got to protect yourself. You ask them to remove any dangers that are there. Sometimes if there are guns in the house, they're left open and out. You can ask those to be removed.
And I was on triage, and I had to go out to a houseboat. I put my bag up on the boat, and now I'm thinking, well, the worst that was going to happen is I was going to get wet. But there was a patient inside, and we know he was uncomfortable. I'm trying to get in there to help, so it wasn't pretty, and I had a skirt on, and I threw my bag up there, and then I kind of just threw a leg up in my body, and I rolled in into this boat, and then it's a tiny little boat, and she tells me, oh, he's right down here around the corner. I'm thinking, around the corner? I'm thinking, I see this whole boat. Well, there is this little doorway. You had to go down into that, and I said, well, where's the steps? Sometimes she goes, oh no, you just step on the counter and hop over here, and then if you put your foot down here. I was dying. After I get all this, I got sweat, my hair's a mess, I've got pieces, I'm all untucked, and I'm like, hi, I'm Lauren from hospice, I'm here to help you. And sometimes you don't know what you're gonna get into.
I arrived at the house and there were no numbers on the house. So I was a little concerned, so I immediately called the Access Center and I let them know that I was going into a house that didn't have numbers on it. I went in and the patient was in a little room in the corner on a double bed that didn't have any sheets on it, and there were cats. There were probably about 8 cats running around. She needed a hospital bed and she couldn't move around very well, and I had to assess her as well, so I'm getting gloves on and kind of gowning, protecting myself. But she was in pain, so it all worked out and we got her on board, and she was much more comfortable after I left, and there were bugs. I mean, it was just not good because it was the conditions that were bad. It was probably one of my favorite admissions, because when I left there, had I not been there that night, it would have been really bad for her. We make every effort to make sure that we can serve them, but first keep ourselves safe, because we don't want to, if we're not around, how are we going to be able to help them?
And the disparity can be a really amazing thing. I could go to those homes at 9 o'clock in the morning and then go 20 miles away for my afternoon visit into a palatial mansion. You see the poorest of the poor, the richest of the rich, and you have to treat them all the same. You're never on your own. Again, you're the nurse, you're the primary contact, the one they see the most, you and the CNA, but you also have the support, and you just have to call them. The social workers, where I've worked everywhere, are wonderful. Phone call away. The chaplain, sometimes they need the chaplain. Phone call away.
When you're out there, you're not alone. You're not the only one that takes care of the patient, because I think most nurses like to take ownership, and it's like, that's my patient, I have to do everything for them. We have so many resources with our IDG team. They're the social workers, the chaplains, the CNAs, the doctors, our team coordinators, our CDs, who are part of the team and more than willing to help out. You don't have to own everything.
Just to give you one example, I think last week I had 2 admissions, a transfer, and a death that pretty much occurred all at the same time. The second admission had came in the door, but I really hadn't started the first one, so I had 2 admissions, a transfer, and a death pretty much all at the same time. I mean, I can rely on my hospital knowledge in terms of sequencing in terms of what do I need to do next, what's the most important thing. However, in that instance, I actually had to involve 2 coworkers, which that's the nice thing about working the day shift. We have our clinical director is very willing to jump in and help. It's comforting to know that there's people that will lend a hand if you need it.
When I need somebody, not just in a medical sense where I need to call someone, if I just need to vent to somebody or discuss something, maybe a problem or an issue or a concern that I have about a patient, I can always call somebody on my team, and it doesn't have to be just another nurse, but it can be anybody. I have seen the teamwork defined within Tidewell.
The team is vital. You can't live without one member of the team. And you know, it's a funny thing. You think one would be more important than the other, but it's just not true. Everybody has a completely different role, and it's a beautiful thing when you see all the pieces of that puzzle fitting together.
With the doctors, the chaplains, the social workers, and even the entire Tidewell organization. It's not just individual houses and individual teams. Tidewell is one big team entirely.
If somebody is thinking of working as a hospice nurse, I have to tell you, you are going to see a lot of deaths. You have to have an outlet, something for yourself that you're able to exhale all of this, because you have to give a lot of yourself, not just to the patient and seeing that the patient's comfortable, but even more for the family who's mourning the loss.
Well, I still remember my first patient that I had in hospice that died, the first patient that died, and yeah, you do. You get attached to them, and it's sad, you know, it's very sad. But you learn a lot about yourself, at least I have, through those times. It's a lot of self-reflection, I find, when you're dealing with people who are dying, and especially when you get attached to them, because now you're invested.
I went my first 3 or 4 months with hospice without even having a death. I couldn't have it checked off on my orientation checklist because I didn't have one. And then they just come. Mine happen to come in 3s.
Again, that is the assumption that everybody's 100 and dying of cancer. Which is so not true. The younger patients are, to me, the most challenging. They're the ones that frequently have the really severe disease processes going on, and you actually walk with them through the ravages of their body. The bodies are younger, stronger, and so processes go on much longer with them, and things feel and look and are more severe at times. That is one of my greatest hospice challenges, is to walk to the end of a young person's life with them.
I just pictured, death as being kind of quiet and easy, and people are just easing into it. But it's not always that case. I've seen the deaths that are painful, the deaths that are not quiet, not pretty. I've seen people that are not accepting of death. That's one of the hardest things, when they're not ready for it and the family's not ready for it.
That's the question that they follow me out to the car with. The family will come out and, so how long do you think he has? Nobody knows, and that's exactly how I answer it. I said, I can't tell you. But anything further than that, unless I see that they are imminently dying, I don't say, oh well, it's going to be 6 months and 2 days. So there's no way that we can tell, and everybody asks.
You focus on living, not on the patient death. You focus on the time they have here with their families, and the time the patient has here, and what we can do to make this process better for the patient and family.
Honestly, if they're asking you a question, I think they want an honest answer, and they deserve it. And compassion, because you've got to do it compassionately, because many people are afraid of death. And
of course, it can be physically and emotionally exhausting, having to provide that support and watching people go through these grieving processes.
You do have the deaths, and some of them I tear up at. I'm not sure why, because others I don't. The things that I find the hardest is when the men start to cry. They're always just strong men. Men don't cry in front of people, so that just tears at my heart, and I'll just start tearing up, and it's okay. It's all right. You're gonna see death. You're gonna be there. That's part of life. That's how it is.
have other things that bring you joy and love, because those things will get you through the sad moments that you have with families. You know, for me, it's my family.
People have in their mind that that's what hospice is, that it's all about death. It is so not. This job is so about life, and that's the part of this job that I love so much, is up till the death. You know, that's only 2% of the whole job of hospice nursing. You know, the fulfillment comes from the other 98%.
What's been new with you?
Nothing much.
No?
I love you.
I love you too.
Really?
When I found hospice nursing, it was like coming home for me. It was like I figured out what I wanted to be when I grew up as a nurse.
I was so impressed when they'd come on my floor and would just talk to us about the patients, or just watching them interact with the patients. And so I was like, you know what? Someday I'd like to be a Tidewell nurse.
When I was in long-term care, we'd spend so much time taking care of these patients, and we'd be at their bedside and think we're doing such a good job, and then the hospice nurse would walk in and the family would just be relieved and they'd all hug her. And
honestly, it sounds probably kind of sappy, but for the most part, people that work here are really nice. They're really nice people. You can work well with them. They're not coming at you with attitudes. They're coming at you with willingness to help and to get things done. And that I love about Tidewell.
To me, this is the most perfect form of nursing. You get to spend quality time with the patients. You're working with an intensity that is fulfilling. Every day it's something different. You have no idea what the day will hold. And so you're constantly challenged. It's a very challenging type of nursing, but fulfilling at the same time.
We have families that tour the facility prior to their loved one coming here, and they just, you know, they just wish that the rest of their experience within medicine could be like this. And that's how I feel too. I'm like, oh, too bad we have to wait till the person actually dies for their experience to be this rich and rewarding within medicine.
I think I changed since I took this position. I really do. I think that you become humbled, and I think you just value things so much more. You value little tiny things that I don't think I really ever valued before, that you realize that this life is not forever.
When I first started working for hospice, I thought it was, the hospice nurses that I met were a lot older. And I thought that working for hospice was something you did kind of at the end of your nursing career, because it was, you know, you didn't have to run around like a chicken with no head at the hospital running around. You could sit down and take it easy, and it's kind of an end of career type of job. But I found it's the opposite. I use my clinical skills and my critical thinking skills more intensely in this situation than in the hospital.
There's really not a day that I could ever say I did not want to get up and come to work.
I think it's a calling that people have. Certainly I knew I wanted to be a hospice nurse. I don't know many people who can say that.
You real quickly figure out either you love it or you hate it. There's no middle ground with hospice nursing.
You have to be aware that the first 6 months is going to be kind of tough. You're going to be experiencing a lot of death. If you can get past that, then things just get, you get so much joy from this job.
I don't think everybody's cut out for hospice nursing. It's the hardest I've ever worked on a job and loved it. Knowing that every day that I'm using my gifts to help other people.
Well, we hope you've enjoyed our video, and we hope that you have a better understanding of the various nursing roles here at Tidewell. We also hope that this video has answered some questions for you, or that it's generated questions that we can discuss further. We thank you for taking the time to watch this video, and we look forward to discussing opportunities here at Tidewell with you.